Good evening, everyone. Welcome to the 30th webinar of this series. I think there's some wrong connection issue with Dr. Mahesh side. At the outset, I thank all for your interest and support. And it's been very nice to have all the SIG. We are having an SIG of stroke this time. And we are going to be, before that, I'll ask Sangeeta to talk about the NeuroCon, which is an annual conference coming up in Vellore.
Good evening, everyone. On the behalf of organizing committee and as well as AOCN team, we invite you all to for the 14th annual conference of Association of Child Neurology of India, which is happening on 8th to 10th February 2022 at CMC Vellore. We have an exciting academic schedule with one-day free pre-conference workshop, having 5 pre-conference workshop, including neuroradiology, pediatric sleep disorders, electrophysiology, neurodevelopmental and behavioral pediatrics, pediatric epilepsy syndromes. And we have a 2-day scientific program with 15 international faculty and 80 over national faculty. So the main conference begins on Friday, February 9th with a dynamic academic schedule, and the day concludes with an evening of entertainment and delightful banquet dinner. And the next day of the conference, we have again exciting academic program with including all subspecialties of pediatric neurology, and the day concludes with a grand valedictory function. So the abstract submission is already open and early bird registration is already open. Kindly submit your abstracts at the earliest and register for the conference soon. Looking forward to meeting you all at the Vellore. Thank you, ma'am.
Okay. Thank you, Sangeeta. Mahesh, want to say some introductory comments? Mahesh? Okay, today we'll be having the, I think some connection issue from Mahesh's end. Today we'll be presenting cases of acute stroke from across India. We have going to be having 3 experts. Can I have the slides, Smita? Can I have the slides, Asmita, of the experts? Yeah. Dr. R. Lakshmi Narasimhan, Director Professor. He's basically now heading the Ramachandra College and Institute. And he's an amazing neurologist with such a great clinical acumen. We are really grateful that he's been able to join today. Last week, he was unable to join because of the cyclone. Thank you, sir, for joining. Next, as the expert, we have Dr. Lokesh Lingappa, who is a consultant pediatric neurologist in Rainbow Children Hospital, Hyderabad, and he's president-elect, and he's an amazing professional. And thank you, Lokesh. And can we have the next slide for Dr. Biju Hamid? Dr. Biju Hamid, he's consultant in Gosh, and basically currently he's heading the services in the UAE and starting to establish pediatric neurosciences. He'll get delayed in joining. He's in another meeting. And the session will be moderated by Dr. Anju Agarwal, who's a dear friend and a very senior pediatrician with the interest in pediatric neurology and has been practicing pediatric neurology for many years. And she's director professor and head in the University College of Medical Sciences, New Delhi. Thank you, Anju. Over to you, Anju, but I will request Harsh to keep the time. Harsh, can you please tell about the timings to everyone, and we'll be
I have a message about the timing. So we have 10 minutes of 10 minutes of presentations and 4 to 5 minutes of discussions.
So at 9 minutes, you will just say 9 minutes, and rest,
Sure.
Dr. Anju will be introducing everybody, all the speakers. Dr. Anju, all is yours. The timekeeper is Harsh. Okay? Thank you.
Thank you, Dr. Shefali and the team for allowing me to moderate this session. It's always an interesting learning from the youngsters. The presenter will be Dr. Krishna, and the session will be moderated by Dr. Kavita Shivastav from BVDU Medical College, Pune. So over to Dr. Krishna.
Good evening. Am I audible?
Yes, audible.
Okay. A tale of missed opportunities. It's about a 13-year-old boy who presented with 2-week history of headache. He had vomiting and fever for 1 day and a cluster of 4 GTCS, each lasting 2 minutes. He was well in between, but after the last seizure, he became encephalopathic. There was also positive movements on the left side. At admission, he had a GCS of 7/15 with anisocoria. He had generalized hypotonia with a power of 3/5 on the right side and 1/5 in the left side. The tendon reflexes were brisk on the right side, and on the left side, it was not elicitable. Plantars were bilateral extensor. He had a liver of 3 centimeter palpable in the right costal margin. In view of seizures, encephalopathy, and hemiplegia with no cranial of palsy, the lesion was localized to the right cortical region, probably frontoparietal in view of motor cortex. The differentials considered were subacute stroke, probably venous thrombotic, or a subacute arterial stroke, or acute demyelinating encephalomyelitis or TB meningitis. On further examination, the child was having a marfanoid habitus. He had thick glasses, long narrow face, and high arched palate. His height was more than 95th centile. Arm span was 4 centimeter more than the height. He had long, slender fingers and toes. Stroke protocol was done, which showed multiple intraparenchymal hemorrhages with infarct and perilesional edema in the right frontal region and a midline shift. And diffusion restriction was noted in the same areas. And post-contract venography was showing thrombus in the superior sagittal sinus. Turned out he was an old patient of ours who was lost to follow-up for over 5 years. The family history was there was consanguinity, 3rd-degree consanguinity, and an infant death in maternal side, and a similar child, a male child with similar phenotype without stroke in the maternal side. And this child had presented for behavioral problems during that time. There was history of hypospadias, inguinal hernia operated when he was an infant. He also had bilateral lensectomy done for intranasal subluxation of the lens. And this was the child at that time. And during that time, he was investigated. His urine nitroprusside was strongly positive, suggesting suggesting increased homocysteine in urine. And serum homocysteine levels was also high. Urine amino acid TLC was done, which showed significantly high levels. And TMS was showing raising methionine levels as the cocktail was added. The cocktail which was started was methylcobalamin, pyridoxine, and a methionine-restricted diet. At that time, betaine was not available and he was not put on that. Echo and MRI brain was normal during that time. He was well for 3 years and on this cocktail, and then he was lost to follow-up. They by themselves stopped the diet and supplements due to severe behavioral issues. He later presented 5 years later. Coming back to the current admission, his EEG was showing encephalopathy, and he had a stormy PICU course with a pleural effusion. And at discharge, his modified Rankin score was 5. He was started on injection enoxaparin at therapeutic dose, which was later converted to oral rivaroxaban. And methylcobalamin, pyridoxine, folic acid, acylcarnitine, and betaine were added. At admission, his homocysteine was more than 50. And on follow-up, at 3 months, it was 152 with a corresponding methionine at TMS of 649. At 6 months, homocysteine was 128 and methionine 598. So final diagnosis is homocystinuria with CVST and hemorrhagic infarct with left hemiparesis. On follow-up, at 3 months, he had gliotic lesions in the right more than left frontal regions with blood products. He was ambulant by this time with a GM-FCS of 3 and a modified Rankin of 4. And at 6 months, there was partial recanalization of the superior sagittal sinus. And by 2 years, this Jan 2023, he is still dysarthric. He has residual hemiparesis with a GM-FCS of 2, and MRI was showing complete recanalization of the sinuses with gliotic scars. He has a sister who was born in 2014. She was detected early at the age of 3 months and started on diet and supplements. Other than mild intellectual disability, she has no lens subluxation or thrombotic events, and she is under regular follow-up. Companion case, we also had a 10-year-old female with a seizure. Parents said that the child is becoming fairer and more dull. On examination, she has light hair and a higher arm span. And there is also history of infranasal subluxation of the lens. She presented with a superior sagittal sinus thrombosis without any weakness, and her homocysteine level was 152. And now she is on a methionine deficient diet, TMG, and methylcobalamin. Mild intellectual disability is there. Other than that, she is doing well with the recent scan showing recanalization. And she turned out to be a CBS mutation. Her parents and siblings were screened and all of them were negative. Homocysteine is an intermediate in the methionine degradation pathway. It requires folic acid and folic acid as a methyl donor and methylcobalamin as a cofactor. It can be caused mainly by three forms. The first one, which is classic homocystinuria, is what is seen in 90% of the cases. It is due to cystathione beta synthase deficiency. And the second is defects in the methylcobalamin pathway. And the third is defects in the MTHFR pathway. So regarding our cocktail, where the medicines are active, betaine or trimethylglycine acts as a methyl donor. So it opens up an alternate remethylation pathway for the conversion of homocysteine to methionine. And it is easily available, well tolerated. It comes in powder form or capsule form. Disadvantage is that the high methionine levels, which come as a result of using betaine, and the methionine test is expensive. Then methylcobalamin tablets can be used, which also act as act as in the MTHR pathway, and pyridoxine, which is a cofactor, and folic acid in the MTHR pathway. Mechanism of stroke in homocystinuria, there is a lot of chemical reactions going on. The reactive oxygen species, which is formed during the auto oxidation of homocysteine, it causes endothelial damage, and this endothelial damage might be a cause for the ischemic stroke. Also, the oxidation of LDL can be due to the reactive oxygen species, and this oxidation of LDL can trigger platelet activation. And DNA methylation and epigenetic modifications are also mentioned in genetically predisposed people. Also, there is cytosolic calcium dysregulation, and there is
3
also
minutes is left.
homocysteination of the protein C and S. And there is impaired fibrinolysis. Also, there is derangement of coagulation factors and natural inhibitors of coagulation. And another problem is accumulation of adenosyl homocysteine, which inhibits the methyl transferases. All of these are said to contribute to the ischemic stroke. The learning points in patients with a murphinoid habitus, behavioral issues, and fair complexion, it is worth investigating further, as there are manageable conditions that improve the quality of life immensely. Eye abnormalities might present after the age of 3 years, and complaints to low methionine diet is a challenge due to the behavioral problems seen in these children. Sibling and parent screening is important for early detection. Early diagnosis and appropriate diet with supplements can prevent catastrophic events like lens subluxation and thromboembolic events. And parents can be counseled for compliance, as prevention is much cost effective than management after the complications arise. These are my references. Thank you.
Thank you, Dr. Krishna, for highlighting an important case. Over to Dr. Kavita for comments. Dr. Kavita?
Yeah. So am I audible?
Yeah, you are audible.
Yeah, so this was a case which really tells us the tale of missed opportunities, because when he came to us initially, that time we had started the cocktail, and then the parent did not realize the importance and did not even do a genetic testing. And after that, then they were lost to follow up, and this child landed up in a very bad stroke kind of presentation. So the cocktail actually has very high doses of all the components. I don't remember the exact doses, but I think Krishna maybe can tell that. And so this, whether it is pyridoxine responsive or unresponsive, I think that is based on the genetic testing. So the other girl had pyridoxine responsive. So there can be varied presentations. This girl, both of them presented with severe headache as an initial manifestation of cerebral venous thrombosis. So in the right setting, at least we should suspect first cerebral venous thrombosis, because it is most often not suspected. And when the child lands up in a stroke, then only we realize that this is actually venous thrombosis going on. So any child coming with unrelenting headache and in the right setting should be definitely considered whether there may be some venous thrombosis going on. So that is the take home message I want to give.
Thank you, Dr. Kavita. Over to Dr. Lokesh.
Yes, ma'am. I think it's a very important point while investigating for the children with stroke, both arterial ischemic stroke and venous stroke, that homocysteine should be considered. And the handle which already was discussed by Dr. Krishna was any hypopigmented hair, even in the absence of lenticular dislocation, some hypotonia, even absence of morphinoid habitus, is a handle for homocystinemia. And always we need to ask for, usually most of the labs initially they give us more than 50. We should ask for further titration. And then later on they have got the levels as 150 and other things, because if you don't have a baseline, if it sells just more than 50, it becomes difficult to follow up whether your treatment is working or not. So it's important to speak to the lab. And they can have varied manifestations, both as we hear the venous stroke, and some children can have arterial ischemic stroke as well. Thank you.
And the other expert, Dr. Lakshmi Narasimhan.
Yeah.
Sir, you have to.
Yeah, good evening. And in fact, even I'm the odd man out. I'm an adult neurologist in the pediatric group. Anyway, just wanted to add that especially in MTHR, the methyl tetrahydrofolate reductase gene, ascorbic acid is a very big role. So it's one of the important cofactor in the MTR itself, where in cases where there's sometimes in resistant adults, what we observe is there are certain cases which are resistant in when we give the supplements in homocystinemia. What we do is we add ascorbic acid as an adjuvant, which helps in recanalization faster. This is my personal experience, and since ascorbic acid is a cofactor in the conversion of tetrahydrofolate acid, and it helps. And it's a wonderfully presented case. I congratulate the presenter. And in adults also, even today, adults also, homocysteine is a very, very important risk factor in both venous and arterial ischemic strokes. Thank you.
Dr. Sangeeta wants to know what was the dose of pyridoxine tried. Some of the questions Dr. Krishna has already answered in the chat box. Dr. Kavita or Dr. Krishna, you like to answer what was the dose of pyridoxine?
So our question to the experts, which we could not find an answer to, is how long do we continue with the rivaroxaban? Because this is a lifelong condition, and because of a lot of behavioral problems, we may not be able to achieve the very ideal homocysteine levels. And they keep on fluctuating with the diet and with the compliance to the medications, as well as the special diet which has been advised. So do we continue, because this is such a devastating complication? What is the, because we didn't find any single guideline which says, even the stroke experts I've asked in during one of the previous stroke sessions, how long do we continue the anticoagulant? So if anybody can shed any light on that.
It is normally it is highly cost prohibitive. So rivaroxaban, what we tell them is the importance of the diet and the supplements, and that would force them to be compliant. That's what I have observed. I tell them the risk and tell them that this is the cost involved in. Normally, the recanalization around 6 months, it completely recanalizes, and after that, the need for the NOACs becomes lesser. But only for a prophylactic thing you would require for a long term. But what I would suggest is, if you really want to avoid another disaster, you stick on to the diet and the supplements which we give. And most of the patients, at least an adults population, they ensure that they stick on to it.
Thank you, everyone, for the interesting case and the interesting discussion. Now we can go on to the next case. The certificates will be given by Dr. Mahesh and Dr. Shefali. The next case will be presented by Dr. Diksha Gupta from AIMS Rishikesh. The moderator is Dr. Prateek Kumar Panda.
Good evening, ma'am. My slides are visible.
Yeah, your slides are visible, but yeah, they're visible.
Okay. So good evening, everyone. Today I'm going to present a leopard attack, case of leopard attack causing stroke from the Department of Pediatric Neurology with the help of Dr. Prateek Kumar Panda, sir. So we had a case, Master T, 12 years old boy, resident of Bijnor, UP, who presented to us with the chief complaints of multiple lacerations on the neck after an alleged history of leopard attack, following which he had headache and vomiting, followed by vertigo and gait instability for the last 3 days. So after this leopard attack on the child, which was during the evening while he was playing, he had multiple lacerations from which he had bled profusely. And he was taken to another hospital where 1 unit of blood was transfused, and he was referred to AIMS Rishikesh after that. He had severe neck pain and headache, moderate to severe, which persisted throughout the day, and it was associated with multiple episodes of projectile vomiting, which were 1 to 2 episodes containing food particles. Also, he had a history of dizziness and vertigo, had reduced response to commands, but he could indicate his daily needs. Also, he had gait instability and difficulty in taking turns. However, there was no history of seizures, involuntary movements, any visual hearing impairment, drooping of eyelids, diplopia, deviation of face towards one side, pooling of secretions, or any loss of taste to suggest any cranial nerve involvement. And there was no tingling sensation or numbness in the limbs and no history of difficulty in breathing. On examination, we could see that there were multiple aberrations over the back with scalp formation, and also there were multiple lacerations over the neck. The systemic examination was non-contributory, and there was nothing to suggest a pneumothorax, cardiac tamponade, or an intra-abdominal bleed after this trauma. His higher mental functions, he was drowsy. However, he was responding to commands and had intact memory and speech. The all cranial nerves were intact, and there were no signs of Horner syndrome or reduced sensations over the face. The tone was normal in all the 4 limbs with preserved power and normal reflexes. However, he had bilateral upgoing planters. He had cerebral signs in form of gait ataxia, slurring of speech, positive finger-nose test, and heel-shin test. Dysdiadochokinase was also present. However, nystagmus was absent. The sensory examination and proprioception was completely normal. So we kept the possibility of a post-traumatic injury like cerebral contusion or hematoma upfront, or it could have also been a cerebral concussion post-trauma. Another possibility we kept was of a vascular event, which was probably a posterior circulation stroke. I would like to localize it anatomically to the cerebellum, probably due to involvement of the vertebral artery or its branches, and can be due to vertebral artery thrombosis or dissection secondary to trauma, could be extracranial or intracranial. The points suggesting a post-traumatic intracranial hematoma or contusion would be history of trauma, headache, and altered sensorium and dizziness. Also, there was overlaying skin discoloration. Posterior circulation stroke is also high on the cards, as there was a history of trauma followed by headache and vomiting, with cerebral signs in form of gait ataxia and slurring of speech. I would like to give the possibility of extracranial vertebral artery dissection more than the intracranial vertebral artery dissection, as literature suggests that neck pain, dizziness, and vertigo are more commonly seen in extracranial vertebral artery dissection. So we went ahead with the MRI brain for our child, and we could see that the axial sections of the MRI brain, and that there were T2 flare hyperintensities in the cerebellar parenchyma, in the cerebellar regions, in the anterior inferior cerebellar arteries and in the posterior inferior cerebellar artery territories. However, there were no similar lesions in the medulla pons or the midbrain, and in the rest of the cerebral parenchyma. Similarly, in the DWI sequences, we could see that there was diffusion restriction with corresponding low values in the ADC maps. And in the SWI sequence, we could see that there were foci of interspersed foci of blooming in the SWI sequences with positive filter face images suggesting of punctate microbleeds. In the MR angiography, we could see that there is non-visualization of the right vertebral artery. Also, in this image, we can see that there is non-visualization of the complete V1, V2, V3, and V4 segment of the right vertebral artery as compared to the left vertebral artery. In the top sequences, we could see that there was absent flow-related enhancement in the right vertebral artery as compared to the left vertebral artery and in the both internal carotid arteries. Also here we can see that there was absent flow-related enhancement in the right vertebral artery. It could be because of vertebral artery dissection or thrombosis, which was confirmed with the help of CT angiography, which showed the intimal flap in the V1 segment of the vertebral artery. So our final diagnosis was that the child had a comminuted fracture of the right transverse process of C1 and inferior articular process of C3 vertebrae, and a traumatic dissection of the V1 segment of the right vertebral artery with a thrombosed V2 and V3 segment, along with the right cerebellar infarct with hemorrhagic transformation. We did a E-fast ultrasound in the emergency itself, and it was normal. Cervical collar was applied to stabilize the cervical spine. Tetanus toxoid and rabies post-exposure prophylaxis was given. As fundus showed grade 2 papilledema, so raised ICP measures were continued, and he was started on aspirin and enoxaparin. Repeat imaging NCCT was done, which was not suggestive of increase in hemorrhages. Hence, the child was continued on enoxaparin, and on follow-up, he became asymptomatic with no focal deficits or cerebellar signs. We had another case who presented to our center with a history of similar episode of leopard attack, following which he had left hemiparesis, and this child had a internal carotid artery dissection. As we can see that the internal carotid artery is not visualized as compared to the left internal carotid artery. Here, I would like to end my presentation with few key points that about leopard bite injuries. The maxillofacial region and the neck in children are particularly more vulnerable to animal bites because the children have small stature and disproportionate size of head relative to the body. Also, they can suffer injuries like laceration of the trachea, external carotid artery, internal jugular vein, or cervical spine. The take-home message from my case would be that in all cases of leopard or animal attacks, apart from the common post-traumatic injuries, one should always think of possibility of an underlying vascular event causing the clinical presentation. Thank you.
Thank you, Dr. Diksha. Over to Dr. Prateek for comments. Dr. Prateek, can you be speaking louder?
Yes, ma'am. Am I audible, ma'am?
We can't hear you.
Am I audible now, ma'am?
Now you're audible.
Ma'am, the only thing I wanted to point out is in our particular area, this particular type of leopards, they are very close to the locality, and frequently we have 3 cases in the last 2 years who had vascular events following this leopard attack. Mainly they come to trauma surgery. They initially think of this concussion, hematoma, and other thing, but they only sometimes they forget this vascular event. So we need to consider, especially whenever there is fracture of the vertebral, or then we need to have include this angiography in the trauma cases, so that we can rule out vascular events and we can start enoxaparin and aspirin in these cases, whatever is required, depending on intracranial or extracranial vertebral artery dissection. That is the only message I wanted to give to this.
How soon can we do an angiography after a traumatic brain injury?
Ma'am, depending on in trauma, usually the children present to trauma. In trauma, usually they do the protocol is they do E-fast ultrasound and CT of head, and this then on the next morning when the child stabilizes, depending on the condition, if the child is on ventilator or something, then they do on the next. If the child is stable, we can get it done right now. In the like this child was relatively stable, ma'am, as we saw in the presentation. This child presented 3 days after the event to the AIMS Rishikesh. He was managed initially in the local hospital. In such cases, we go upfront with the MRI, but it might not be possible in all the cases, ma'am. And the child is sick on the ventilator.
Over to the experts, Dr. Lokesh. I'm not very sure about the why due to leopard attack you can do an early angiography. Any comments from the experts, Dr. Lokesh?
No experience of this exact condition, but any post-traumatic, even after a road traffic accident or anything where there is a injury of the vertebral body, or there is a risk of dissection, especially the posterior circulation vessels, and the risk of dissection and thromboembolic phenomena are known. So if there is those area abnormality, bony abnormalities, and I think it's worthwhile recording the angiogram early, because if the child is encephalopathic, these small cerebellar infarcts may not be actually symptomatic if they're encephalopathic for other reasons.
Over to Dr. Lakshmi.
We don't think there is no need to delay the angiogram. The moment we know that there is a trauma in the neck and there is a fracture and the patient shows cerebellar, it's obvious diagnosis is is a dissection. So we don't delay. We immediately do the, and in fact, even on the in a cervical trauma presenting as a cerebellar or a lateral medullary syndrome or any of the medullary strokes, we straight away do a CT angio on arrival itself, along with the trauma screen.
Thank you, sir. Any other questions? So then we can move on to the next case. Next case will be presented by Dr. Tanuja. The moderator will be Dr. Mahesh from JNMC Belagavi. So over to Dr. Tanuja.
Good evening, everyone. I'm Dr. Tanuja, DM Pediatric Neurology Resident from JNMC Belgaum. Today, I'm presenting the case of an infarct with normal angiography under the guidance of Dr. Mahesh Kamte sir. There was a 10-year-old girl who had complaints of vomiting and giddiness, which lasted for a few minutes. Following this, there was weakness of the right upper and lower limb, reduced clarity of speech, and deviation of angle of mouth to the left. The speech involvement was mainly in the form of a dysarthria with normal comprehension and normal word output. There was no history of fever, seizures, trauma, or altered sensorium. The weakness and speech improved over the next 3 days, and this child presented to us on day 7. The past history, family history, immunization, diet, and socioeconomic history were not contributory. So on history, we have right-sided hemiparesis with right facial palsy. And there is speech involvement. So we thought of a probable vascular etiology, probably left MCA territory, involving the internal capsule or corona radiata region. But vomiting and giddiness are significant complaints which made us think of posterior circulation stroke. On examination, the mental status and speech were normal. Cranial nerve examination showed right UMN type of facial palsy. And she also had mild right-sided hemiparesis with a power of 4/5, tone and DTRs being normal. There was no signs of incoordination, and sensory and cardiac system examination was also normal. So our clinical diagnosis was right-sided hemiparesis with right UMN facial palsy, secondary to a probable vascular etiology. And our differentials were arterial ischemic stroke involving the left MCA territory, probably the internal capsule or corona radiata region, or arterial ischemic stroke involving the left PCA territory in the region of upper pons, CSVT, and stroke mimics. The points favoring left MCA territory infarct were right hemiparesis with right UMN facial palsy and involvement of speech, but giddiness was going against this. Vomiting and giddiness were pointing towards a PCA territory infarct. However, there was no LMN cranial nerve involvement. We also thought of CSVTs because of hemiparesis preceded by vomiting. However, there was no altered sensorium or headache, which are significant complaints which are usually seen in CSVT, and improvement was seen within 3 days. Stroke mimics are very common in children, so that was also kept in mind. With this, we went ahead with the investigations. Her hemogram was fairly normal. Homocysteine was slightly elevated, 27, but MCV was 70, and ECG and 2D echo were also normal. We did MRI for this child, and we found T2 and flare hyperintense and T1 hypointense lesion in the left pons, which also showed diffusion restrictions suggestive of an acute subacute infarct. And the rest of the brain parenchyma was normal. MR angiography was also normal. So based on this site of involvement in the posterior circulation, we suspected that there was anteromedial group of vessels involvement which are branching off from the basilar artery and which supply the paramedian region of the pons. So we thought of arteriopathy or dissection and went ahead with DSA. But DSA also turned out to be normal. So then based on the site and size of lesions, small vessel vasculitis was unlikely. So we thought of other rarer causes of posterior circulation stroke, and we did dynamic contrast CT angiography. So in the neutral position, we can see that both the vertebral arteries are visualized. I've pointed the arrow at the left vertebral artery. And on turning the head to the left, again, we can continue to visualize both the vertebral arteries. But on turning the head to the right side, the left vertebral artery is no longer visualized. So in settings where the dynamic CT contrast angiography is not available, we can try Doppler, which is easily available. We did do Doppler in our case as well. So here in the left vertebral artery neutral position, there is a good diastolic flow. But on tilting the head to the right side, there is significant reduction in the diastolic flow seen in the left vertebral artery. So this helped in confirming our diagnosis of Bow-Hunter syndrome. We treated our child with aspirin, iron, and B12, and also advised regarding the surgical resection of cervical osteophyte. A brief note on the posterior circulation strokes in children. We all know that it is a rare condition. 15 to 37% of the arterial ischemic strokes can have posterior circulation involvement. The common causes are arteriopathies, which is the most common cause, including FCA and Moya-Moya disease, arterial dissections, cardiac disease, hypercoagulable states, and cerebral vasculitis. A risk factor is usually identified in 68% of the cases with posterior arterial ischemic strokes. The common cause of delay in diagnosis in these posterior circulation strokes could be because of non-specific and high variability in the clinical presentation, and also presence of good collateral circulation in this region. But 11 to 30% of the cases may still not have an identified etiology, but it is very important to recognize it because the recurrence rate in posterior circulation stroke is much higher than the anterior AIS. A brief note on Bow-Hunter syndrome, which is a rare cause of posterior circulation stroke. It was first identified in 1978 when a bow hunter developed the symptoms during archery practice. During archery, the stance forces the rotation of head in one direction to stabilize the arrow while aiming at the target. It is more commonly seen in males than females. The pathophysiology is that when there is rotation of head to one side, there is a stenosis or occlusion of the vertebral artery. This results in a downstream hypoperfusion of the brain tissue, or if there is a vessel injury, there can be thromboembolic phenomenon. The primary etiologies are osteophytes, herniated discs, tendinous bands, or tumors, and acquired etiologies include complications from cervical spine surgery or neck trauma. So my take-home messages are that children may not be forthcoming with history of vertigo or tinnitus on turning head to one side, unlike adults. In posterior circulation strokes with unclear etiology, Bow-Hunter syndrome should be kept in mind. And dynamic imaging studies must be considered when routine angiography is normal. Doppler of neck vessels is an easily available tool, and it adds on as a good screening tool in such cases where dynamic contrast CT angiography is not available. This is a video of the dynamic CT contrast angiography. So in neutral position, we can see both the vertebral arteries to be visualized. But on turning the head to the right side, here initially we can visualize both the vertebral arteries. But here we can no longer visualize the left vertebral artery when we are tilting the head to the right side. So this helped in confirming the diagnosis in our case. She is due for follow-up in the next month. However, in the past 3 months, she has not had any recurrent events. Thank you.
Thank you, Dr. Tanuja. Over to Dr. Mahesh for comments.
This child presented us with acute onset hemiparesis, and the MRI showed infarct in the posterior circulation, mainly the pons. And the angio which we did was normal. So because posterior circulation stroke, angio can be normal, we went ahead with DSA, and DS also came out to be normal. So we were in a fixed scale, like what to do with this child. Then when we reviewed the literature and we read about Bow-Hunter syndrome, we thought of this as a possibility, and we underwent this dynamic CT angiography, and that could give us a diagnosis. And to work up this case, MRI angiography, then DSA and CT angio, the child had spent almost more than 50,000 rupees actually. So we thought we use some other test to confirm, so that in future, when patients are not affording, can we use some other alternative test. So we spoke to a radiologist and we tried to get this neck Doppler. And that also gave us a very good indication that Bow-Hunter syndrome can be screened using Doppler of the neck vessels. So this is the interesting case we wanted to do in this. Thank you.
There's a question which says, is there any skeletal dysplasia in this child? Can it occur as isolated deformity?
Our child did not have any skeletal dysplasia. We did not have.
Okay.
The child had a cervical osteophyte in the CT. And that was probably the one which led to this Bow-Hunter syndrome.
So Dr. Lokesh and Dr. Narasimhan.
Yeah, nice case, Mahesh and Tanuja. So basically, it's one of the common cause for posterior circulation stroke, the rotational vertebral arteriopathy. which can be associated with strokes, sometimes recurrent strokes as well. Some of the movements which we have seen in few children who came with this is sudden movements while playing badminton, or sudden jerk movements with rapid skating and turning. Those kind of movements have triggered off strokes in some of these young children. And so recently we published a series of around 6 children where they had this rotational vertebral arteriopathy, and all of them went underwent C1 C2 fixation to reduce the amount of vertebral arteriopathy. In fact, one child who had a stroke secondary to this at around 6 years of age, she came back at 15 years of age with recurrence of stroke. She had not undergone the fixation. So the risk of recurrence after such a long period was very unusual. And during the second visit, we were able to prove that a pathology and then did the C1, C2 fixation. So it is something we need to look out for when we don't have other common etiologies.
Thank you. Over to Dr. Narasimhan.
I congratulate the team. It's an excellent case. Very clear. One important thing is, one differential diagnosis is spinal epidural hematoma. What happened? I even recently saw one young boy playing under 10. After bowling action, he developed an acute onset weakness of one half of the body. That was sparing face and a high cervical epidural hematoma was there, and we evacuated. The patient did well. So you should always remember in such conditions the differentials of spinal epidural hematoma, which you should not forget.
So thank you, Dr. Mahesh and Dr. Tanuja. We move on to the next case, which will be present.
Anju, before that, we can ask Dr. Rekha. Rekha is the patron. Dr. Rekha is the patron for this SIG. You want to make any comments, Dr. Rekha, for any of the cases thus far?
If they can put up their hands.
We
can have it the discussion in the end.
No, Anju, I'm asking only Rekha.
Okay.
Dr. Rekha?
She's very much there, but she's not responding.
I know.
Yeah. No, I'm there.
Yeah.
Hello.
Yes, ma'am.
Hello. I actually
Hello.
So my internet is very sketchy. I'm just trying to find out. So I'm kind of getting in and out because anyway, so this was actually really a very interesting case because it will be very difficult one would not even think of a dynamic CT angio in such cases. So yes, it was very well picked up in this patient.
Thank you, ma'am. Now we'll move on to the next case, which will be presented from CMC Vellore by Dr. Uma Mohandas, and it will be moderated by Dr. Sangeeta Yognathan. Over to Dr. Uma Mohandas. Dr. Uma?
Uma, can you share your screen?
Yes, ma'am. Ma'am, is my screen visible?
No, the slides are not visible yet.
Slides not visible?
Yeah. Yes, ma'am.
Zoom meeting. Now your slides are there. Move to the slideshow. Yeah, slides are visible.
Yes. Good evening to all. I would like to present a case of a stroke in a child with MSUD. My moderator is Dr. Sangeeta Yognathan, ma'am. Moving on to the case. We had an 11-year-old girl, second born to second-degree consanguineous parents. She presented with complaints of delay in attaining milestones since early infancy and weakness of right upper limb for 3 days, followed by lower limb for 3 days. Her previous antenatal history was uneventful. She was born preterm at 32 weeks, 1.6 kg, had cried soon after birth, had a history of NICU admission for 3 weeks in view of respiratory distress. She had global developmental delay to start with, but now she is in class 4, has got poor reading and writing skills with ADLs fairly independent. She has a history of hyperactivity, poor attention, and certain behavioral issues. Going on to her timeline, from NICU care at birth, she was fairly doing okay initially, after which she started having recurrent episodes of lower respiratory infections characterized by fast breathing and lethargy, for which she used to require treatment with IV fluids and antibiotics till for about 4 years of age. For the same, she was evaluated elsewhere for both developmental delay and this recurrent infections. And that time, TMS was done elsewhere, which showed MSUD, and she was started on branched-chain amino acid-free diet as well as thiamine supplementation. By 7 years of age, the parents defaulted the treatment, and she was just continued on thiamine supplementation alone. At 8 years of age, she had her first episode of fever-provoked generalized tonic-clonic seizures. That time she had excessive lethargy as well. At 9 years of age, she was again hospitalized with a history of acute gastroenteritis with lethargy. Her present illness, it started recently on 20th of November when she presented to us with history of difficulty in holding objects in right hand as well as difficulty in writing. On 22nd of November, the weakness progressed to inability to lift her right arm above the shoulder. By 23rd, she had weakness involving the right lower limb while walking, and by 25th, she was unable to walk. But there was no history of fever, joint pain, joint swelling, headache, vomiting, no history of trauma, no history of any exanthematous illness, no history of any previous similar episodes. Her anthropometric assessment showed a weight 34 kg between 25th to 50th centile, length was 140 centimeter between 25th to 50th centile, head circumference was 52.5, vitals were normal, no neurocutaneous markers were there. On neurological examination, she was always right-handed, obeyed simple commands, had aphasia at presentation, cranial nerves, no deficits were there. But on motor examination, she had decreased tone in right upper and lower limbs, with right upper limb power to grade 3 and lower limb power to grade 2. Deep tendon reflexes were 3+, with extensor plantar on right. No cerebellar signs or organomegaly was there, and other system examination was also normal. To summarize, this is an 11-year-old girl born to second-degree consanguineous parents with neonatal risk factors, prematurity, neonatal jaundice. To sum up, she has got intellectual disability with acute onset weakness of right upper limb and lower limb with non-fluent aphasia, MSUD, probable intermediate variant, anatomical localization to superior division of left MCA, and probable etiologies were metabolic vasculopathies as well as thrombotic. Going on to her MRI, she had the T2 axial images showed hyperintensities confined to the dentate nuclei as well as dorsal pons, midbrain, periaqueductal gray matter as well as substantia nigra, and subtle hyperintensities confined to the thalamus. There were evidence of chronic infarct, which was involving the deep internal watershed area, and also there was an area of acute infarct involving the left posterior opercular and high parietal parenchyma, and there were smaller areas of acute infarct in the left middle frontal gyrus as well. Areas of diffusion restriction was also noted, which was suggestive of this acute infarct. And in addition to that, we had done her vessel wall imaging, which showed an eccentric wall thickening in the left terminal ICA. Areas of the other these were the major findings which we found out. Investigations, she had a low hemoglobin with features of iron deficiency anemia. Her platelet count was 6 lakh, borderline vitamin B12 levels with mildly elevated plasma homocysteine and a low iron profile. Serum creatine electrolytes LFT was normal. Uric acid CPK, total metabolic workup was also fine. Initial total free and acyl carnitine analysis, vasculitis profile and thrombotic workup was also sent, of which vasculitis profile was negative and thrombotic workups awaited. Ammonia was 109, lactate was 1.25 millimoles. Of the serum amino acid levels which we sent, valine came out as 479, which was elevated. Leucine was also elevated, 221 unit moles, and isoleucine was also elevated. Allo-isoleucine peak was detected. Urine amino acid showed increased urinary excretion of branched-chain amino acids. Echo done as a part of workup was also normal. We managed her with IV dextrose high-calorie feeds, initiated her on low-protein diet as well as thiamine supplementation with vitamin B12 folic acid supplementation, aspirin prophylaxis as well as anti-seizure medications. Going on to maple syrup urine disease per se, it's a deficiency of enzyme branch-chain alpha ketoacid dehydrogenase complex, which is required for the breakdown of 3 branch-chain amino acids, mainly leucine, isoleucine, and valine. This causes an increase in the level of allo-isoleucine in the body. It's an autosomal recessive inheritance. The main pathophysiology is because of deficiency of this excess of branch-chain amino acids, there is elevated levels of leucine, which can deplete the glutamate levels, increase oxidative stress, and that can cause various neurological issues. The various types of MSUD are classic, intermediate, intermittent, thiamine responsive, and E3 deficient, of which our child belonged to the intermediate variety. Stroke and metabolic disease can happen as stroke-like episode as well as with ischemic stroke. Stroke-like episodes are mostly seen with mitochondrial disorders like MELAS, CoQ deficiencies, Golgi-related disorders, organic acidurias, propionic acidemia, glutaric aciduria type 1, type 2, isovaleric aciduria, methylmalonic acidemias. Ischemic strokes are mostly seen with homocystinuria, Fabry's, cystinosis, cerebrotendinous xanthomatosis. Stroke and metabolic disease, the stroke-like episodes which are happening is predominantly due to energy failure, which can cause endothelial dysfunction and tendency of hypercoagulation, cerebral perfusion dysfunction due to aggregation of metabolites, and secondary neurotoxicity. But there is no rupture or obstruction of larger brain vessels. Whereas in ischemic stroke, there is mostly thromboembolic events. The take-home messages with this presentation is stroke-like episodes are described in children with inherited metabolic disorders. The stroke-like episodes needs to be differentiated from ischemic stroke. Ischemic stroke and stroke-like episodes can also coexist. Thank you.
So thank you, Dr. Uma. Over to Dr. Sangeeta for her special comments.
Good evening, everyone. In this child, the maple syrup urine disease, we have not in earlier read or we have not identified any stroke or stroke-like episodes in children with maple syrup urine disease. So this was very uncommon presentation in this child. So when you look at the metabolic disorders, inherited metabolic disorders, stroke-like episodes are more often described. But ischemic strokes can also occur in certain inherited metabolic disorders, particularly those with hyperhomocystinemia and the few of the other disorders which Uma has shown in a table. But some of the disorders, there may be a coexistence of stroke-like episodes, and also they can have ischemic stroke later. For example, in MELAS, early to start with, the children can have stroke-like episodes due to energy failure. But later on a long run, because of the atherosclerosis or because of hypertension or because of cardiac arrhythmias, they are prone to have thromboembolic events as well. So we should not miss out a stroke, a thrombotic or ischemic stroke in a child who has a metabolic disorder. So if you look at the stroke-like episodes, it is often precipitated by a stressor, which results in a metabolic decompensation, leading on to energy failure, as a result of which you can have a stroke-like episodes. So other mechanisms which can cause stroke-like episodes in these children are because of the increased oxidative stress. And also sometimes you can have endothelial dysfunction because of the accumulation of neurotoxic metabolites. The thrombotic events can occur in children, particularly with those with hyperhomocystinemia. We have seen in the first case of this presentation, where she was explaining that endothelial dysfunction because of the elevated homocysteine levels can lead on to the hypercoagulability and leading on to the thrombotic events. So while a child with metabolic disease presents with acute onset focal neurological deficits, the key important point is to differentiate between a stroke-like episodes or a proper ischemic stroke, because the management would differ. So if you're suspecting a stroke-like event, stroke-like episode, then we have to manage accordingly, manage the metabolic crisis and initiate the appropriate diet and also supplement the cofactors. But in case if it is a coexisting ischemic stroke or it is an ischemic stroke, we need to initiate the antiplatelets or anticoagulants accordingly. So in this particular child with maple syrup urine disease, she had both chronic deep watershed infarcts and also she had an acute infarct. Acute infarct was particularly in the watershed regions, And also she in the MRA, if you could see that there was a narrowing of supracavernous segments of ICA, and also in the vessel wall imaging, there was a concentric thickening and enhancement of the supracavernous segment of the ICA. So the possible mechanism in this child is because in maple syrup urine disease, you have deficiency of branch chain ketoacid dehydrogenase, and this enzyme is expressed in large amount in neurons as well as the endothelial cells of the blood vessels. So the possible mechanism is because of the accumulation of branch chain amino acids, particularly leucine, there may be an ongoing chronic endothelial injury, which has led on to the thromboembolic phenomenon and causing like a acute ischemic stroke. So when a child with a metabolic disorder presents with a stroke, it is most important for the clinician to differentiate between a stroke-like event or an acute ischemic stroke to determine the management.
Dr. Sangeeta, one of the participants, Dr. Vijay Patra, has put up a question. Did iron deficiency anemia contribute to stroke in this child?
Stroke in children are often multifactorial. So the child had an hemoglobin of 8.9, the ferritin was low. But we can't say that it's the key factor for causing a stroke because there was a major vessel involvement in this child, and also there was a supracavernous ICA narrowing as well as thickening. So it may be a contributing factor, but it might not be the sole factor for causing stroke. In addition, this child also had a low B12 level and also mild elevation of homocysteine, which again can be add-on factors.
Okay, thank you. Dr. Narasimhan had to leave for some emergency. Dr. Lokesh, special comments?
Yeah, I think that's a very interesting case. We have not had any child with MSUDs presenting. It was an intermediate form of MSUD, was it, Dr. Sangeeta?
Yes, it was an intermediate variant. The child was doing relatively okay when she was on thiamine supplementation and the protein restricted diet, but the family discontinued the diet and also the thiamine for some time. That's a time when she had this neurological event.
Decompensation.
There's a comment from Dr. Kavita which says citrullinemia can also cause strokes.
Yeah, there is urea cycle disorders can also manifest with stroke or stroke-like episodes.
Okay, thank you both to the presenter and the experts. The next case we go on to Dr. Akshata Angati from Belagavi, and the moderator is again Dr. Mahesh. Dr. Akshata. We can see your slides.
Yes.
Good
evening.
Now we
Yes.
can see the slides.
Yes. Good evening, everyone. Respected faculties. Myself, Dr. Akshata, DM Pediatric Neurology Resident from JNMC Belgavi. I'll be presenting a case, stroke mimicking metabolic encephalopathy. Moderator being Dr. Mahesh Kamte, Professor HOD, JNMC Belgavi. So here is a 4-year-old child, developmentally normal, born to non-consanguineously married couple with normal perinatal history, came with loss of consciousness after fall from a bed while playing, with no history of fever or seizure. On examination, he had flexion response to painful stimuli, GCS being 6 and bilateral pupil are equally reactive. And his GCS improved over day 2 or 3 with eye opening to pain, non-specific sounds and withdrawal to pain with GCS of 8. After 3 days, the child was noticed to have a paucity of movements in right upper limb and lower limb with deviation of angle of mouth towards the left, with other systemic examination being normal. So the probable diagnosis would be the acute encephalopathy with right-sided hemiplegia with ipsilateral UMN type of facial palsy. The localization would be left subcortical and internal capsule, but there is also encephalopathy feature over here, which was going against. We went ahead with the MRI brain. MRI brain showed, axial cut showed asymmetric hyperintensities in a bilateral putamina. Diffusion weighted images showed diffusion restriction with reversal on ADC mapping, suggesting cytotoxic edema. So any guesses what would be the probable causes? So the differential diagnosis for bilateral basal ganglia involvement are acute events like hypoxemia, hypoglycemia, and carbon monoxide poisoning. And in a chronic inborn error of metabolism like BT-BGD, Lace disease, MELAS, and other organic acidurias, degenerative diseases, and dysmyelinating diseases like Kenneman's and MLD. So we went ahead with a workup to rule out the metabolic causes. Serum homocysteine level, CSF findings, including lactate, TMS, GCMS, serum ammonia, ABG, all were normal. So with this, we went ahead again, revised the history with history of minor head trauma in a developmentally normal child, and bilateral asymmetrical involvement of basal ganglia. With these points, suspecting mineralizing angiopathy, we went ahead with a CT head. So axial cut showing asymmetrical hypodensities in a bilateral putamen with calcification in the hypodensities. So 3D reconstruction was done. Sagittal and coronal sections showed calcified lenticular striate arteries, suggesting mineralizing angiopathy. So these are the conditions associated with basal ganglia calcification. The point against these are having only these will have a single involvement. There won't be a bilateral involvement, and they will be symmetrical. During the course, the child was put on antiplatelet therapy, oral aspirin, and iron supplementation and physiotherapy. The child improved over 4 to 6 weeks and became ambulatory and had a mild hemidystonia. The brief overview about mineralizing angiopathy, which was first described in 2013 by Lokesh Lingappa sir. It is also called as mineralizing angiopathy of lenticulostriate arteries or a mineralizing lenticulostriate vasculopathy. It is a well-recognized risk factor for basal ganglia stroke after minor head trauma in infants and young children, the prevalence being 2.9 cases per 100 cases, 1000 cases, seen in previously healthy and developmentally normal children between 9 months to 3.5 years. It is rare after 3.5 years. There are case reports of about 6-month to 7-month child also. Slight male preponderance. Iron deficiency anemia has been reported in up to 65 to 69% of Indian children. It because of inflexible microcytic red cells may clump together. CT is a CT. There will be a calcification on CT images. Typically bilateral, punctate, and slightly asymmetric. On coronal and sagittal reconstruction, lineal calcification lesion can be seen. Based on the number of branches involved, the poor the prognosis. Why specifically basal ganglia involvement in these children? Because the lenticular striate arteries create an acute angle, more acute in childhood, and there would be a stretching and distortion of the angle of perforating branches during the trauma. In children, sphenoid bone does not fully cover the temporal lobes, facilitating stretching of lenticular striate arteries, and also maybe due to friction generated between the lenticular striate arteries and the brain parenchyma. In mineralizing angiopathy, the calcified lenticular striate arteries, which are brittle, predispose these children for basal ganglia stroke following minor head trauma. Treatment, since it is associated with iron deficiency anemia, iron supplementation, and aspirin is not effective in preventing stroke recurrences because there is no theoretical basis, and because as there is no arteriopathy or ongoing inflammation or prothrombotic condition in mineralizing angiopathy. Outcome, the complete neurological recovery has been reported to occur in 21 to 63% of the cases, and those with recurrences tend to have a worse prognosis. So this case was published in article Annals of Academy of Neurology. 2 cases were presented. One more was 18-month-old child following a fall with altered sensorium for 5 days, noted to have a stroke and with a similar imaging findings. So here, MRI in mineralizing angiopathy, there will be asymmetrical involvement of bilateral basal ganglia, unlike other diseases where it is symmetrical. And mineralizing angiopathy presenting as an acute encephalopathy with coma due to bilateral basal ganglia strokes is rare. Here, the take-home message is that mineralizing angiopathy is an important risk factor for a stroke after minor head trauma in infants and young children. MRI reveals arterial infarction in basal ganglia region, and MRI will be normal. CT head reveals bilateral punctate and asymmetric basal ganglia calcification, suggesting mineralization. Iron deficiency is a most common accompaniment, especially in Indian children, and majority of the child recover. Thank you.
Thank you, Dr. Akshita. Now over to Dr. Mahesh.
Meningitis angiopathy is an important cause for stroke in infants and toddlers, especially less than
You
4
can
years
stop
of
sharing
age.
your screen.
But usually it presents mainly as an unilateral or one-sided stroke. This child had come to us with bilateral stroke and in the form of encephalopathy, though had one hemiparesis, but child mainly came with encephalopathy. MRI was suggestive of bilateral basal lesions, and we initially thought of metabolic diseases like Leigh disease or organic acidemias, but our workup was negative. And when this history was retaken, the history of minor trauma before the onset of this complaint. So this made us think of meningitis as a possibility, and we did a CT scan, and CT scan clinched the diagnosis. So whether you have a child who presents with hemiparesis or encephalopathy, and you have asymmetric changes, you should always consider meningitis as a possibility. Thank you.
Thank you, Dr. Mahesh. Over to Dr. Lingappa.
Yeah, thank you, Mahesh, for bringing out this presentation. So in fact, we have had children who were diagnosed as Leigh syndrome based on these kind of MRI findings, and the CT has not been done and the complete history has not been taken, and was concerned that the child will rapidly progress and have premature death. So I think one of these, when the things are not matching, the child's encephalopathy improves quickly, and the lactate is not elevated, history of trauma is also there. I think doing a CT scan with coronal and sagittal reconstruction would be a good option so that you make this diagnosis. Not very common to have simultaneous bilateral, but it is well seen in a few children. So that you need to be careful in diagnosing.
Dr. Mahesh, there's a question from Dr. Rashmi Kumar which says, what was the cause of encephalopathy here?
Because of bilateral involvement, bilateral basal involvement. It's a very transient, ma'am. It is only for about 2 to 3 days. Then the baby improved, ma'am. Yeah.
Okay. So I think we have the last case now. It will be presented by Dr. Abhijit from KEM Pune. So over to Dr. Abhijit.
So, yeah, am I audible in my slides are visible?
Yeah, slides are visible, you're audible. Slides are not on the slideshow mode.
Sure. Yeah, just put it here. Yeah.
They are still not on slideshow audio.
Now, are they moving?
I think you'll have to share the screen again.
Yes. Now?
No.
In this post, just stop.
We can see your slide, but not the slideshow.
Now?
Now we can't see anything. You try loading again.
Abhijit, stop sharing the screen. Stop share. Now, what you do, you share, once again, you share your whole screen. Don't share the slides, wala. Share your whole screen. Okay. And after you share your whole screen, then you maximize your slides. That's why, we request you to join at 7:30 and do this.
Sorry. Yeah. Are they visible now?
I think your internet connection is weak. We can see that you're sharing the screen, but the screen has still not come up. Now we have the slides.
Yeah.
Okay.
Are they moving?
You can proceed.
Yeah. Yeah. Very good evening, everybody. I just my video. So, I would like comments.
Your voice is breaking.
As well as I would like to have the expert comments about the diagnostic as well as the management point of view in this case as well. So I hope I'm audible now.
Yes, you're audible now.
Yeah. So this is 6 year, 6 months boy who came with a fever since last 10 days, which were on and off. So the fever was around 100, 101, which was mild to moderate grade. I mean, it used to 1 to 2 spike per day, and couple of days it was a febrile as well. And then he started headaches since last 4 days, and the headaches were mainly predominantly bifrontal, early morning, and they used to subside with antibiotic and never used to be severe and disabling. Then he had one episode of giddiness.
Your voice is breaking again.
Hello, ma'am. He has a very low bandwidth.
Okay.
Mansi, you can switch
Hello?
off this video so that it will save the bandwidth.
Yeah, so video already switched off.
Okay.
Yeah. Shall I go ahead? And he had right upper limb weakness in the form of he's not able to hold the things are slipping from his hand, and he's walking. Started walking difficulty, started swaying and not able to walk properly where he could stand, but standing on either legs become difficult since last 4 days. I'm audible.
Yes, sir. You're.
Yeah. So he was hospitalized for a month back, with a fever, cough, cold, and malaise in a peripheral hospital for 5 days, and he received symptomatic treatment for the same in form of some IV fluid and IV antibiotics. He had normal birth details, developmental milestones. He was adequately immunized and doing excellent in the schools on a background of no past significant history and non-contributory family history. So on examination, his vitals were normal. His BPs were within centiles. He was toxic looking. He was febrile then. His peripheral pulses were well felt. His spine was normal. There was no neurocutaneous markers. There was no rash. On CNS exam, he was well nourished. His height, weight, and head circumference was age appropriate. He was conscious oriented and his speech was normal. His external eye movements and fundi were normal. Other cranial examination was normal. He had right upper limb weakness, that too more on a distal part, so he can't grip the things very well. The opposition of the fingers is not possible, and he had dorsiflexion difficulty in around his wrist, but his elbow and shoulder power is around 4/5. Lower limb power was good. His DTS cerebral sign positive in a form of gait ataxia. Tandem gait was positive, and as I said earlier, he couldn't stand on either legs. There were no meningeal signs or no other signs of raised ICP. So his cardiovascular system had normal heart sounds and no murmur. Per abdomen was normal, no organomegaly. His respiratory system was normal. Musculoskeletal was normal, no joint pain, no tenderness. And as I said, the spine examination was normal. There was no dimple or any kind of a sacral pit there. So what was the clinical impression? It was acute to subacute febrile illness with an episode of giddiness with impaired consciousness. Could be a seizure, could be TIA vascular, and with right hemiparesis with cerebellar signs, without meningeal or raised ICP signs. So definitely we thought more of an infective versus parainfectious versus autoimmune, and little down on the line, demyelination was one of the thoughts. So with the same complaint, he was admitted, started on IV fluid, started giving IV ceftriaxone, acyclovir, azithromycin, and mannitol. His initial workup showed HB of 12.4, WBC count of 12,900 with polymorphic predominance. His platelet count was high, 5.95. His CRP was earlier admission was, couple of days ago was 4, and now it becomes 16. His ESR was 40 at the end of 1 hour. His electrolyte, SGPT, BUN, creat were normal, and X-ray was normal. So looking at all this scenario, MR and CSF studies were planned. So this was his MRI. This is FLAIR images showing the hyperintensities in left side of the pons, left side of the midbrain, bilateral cerebellar hemisphere, brachym pontis, and it is there also in gray matter of the cerebellum, as well as there is tiny hyperintensity in left thalamo-capsular area. So when you see restricted diffusion and ADC map, there was hardly only the thalamo-capsular, hyperintensity was little had a restricted diffusion. But all intensities were more of a T2 channel. There was no ADC showing corresponding diffusion. This is contrast imaging, which doesn't have much of contrast enhancement, no basal exudates, nothing. Angio was done. Angio was showing his intracerebral part of the right vertebral artery was kind of narrowed, His bacillar was hypoplastic, where it was not well visualized, and PCA reported was a fetal origin or hypoplastic. Rest anterior circulation was normal. This is the angio in a closet, which again showed a similar finding. The bacillar, you can't make out really good flow voids. His PCA were there, and his right vertebral was hypoplastic. So looking at, and along with it, he had also had enhancement and hyperintensity in right aspect of the right optic chiasm, and he had focal thickening and enhancement of right nerve root of cauda equina, majority at L2 and L3 segment, and he had right basilar artery stenosis. So this, imaging were not in favor of stroke either, because this history was acute. So ideally we would expect, restricted diffusion lesions in this particular kind of a territories. But looking at angio images, definitely a differential of autoimmune versus vascular was kept. So we did a CSF. CSF showed 76 of protein with 25 of sugar, 1 of corresponding BSL. His cells were 550 with polymorphic predominance. CSF culture, gene expert and stain were negative. CSF biophager, fire, which was extensively, had those neurotrophic viruses, bacteria, and even mycoplasma, that was negative. He started on aspirin, started on IV vancomycin meropenem because he was spiking fever, and added azithromycin looking at atypical and maybe mycoplasma in this thing. And he was dwelling from the rural background. So there was no really exposure to cat and kind of dogs and cattles, but doxycycline has been added thinking of the rickettsial pathology. Though he had this basilar artery narrowing, we did a 2D echo, which was normal. PTA-PTT was normal. He had low B12 with normal homocysteine, sickling, HB electrophoresis, and lupus anticoagulant were negative. So patient got symptomatically better, but headache continued. His hemiparesis started improving. Where, we again, because looking at his pleocytic CSF with high protein and low sugar, we again thought COX is one of the differentials. So MI2 was done, which was negative. Family screen was done, was normal. There was no family history of COX in past. His ESR was 40, GAFB and gene expert on GA was negative. His USG and X-ray, as I said, was normal. There was nothing on the X-ray showing mediastinal widening or mediastinal lymphadenopathy. Wilflix and scrub typhus IgM was negative. His ANA blot and PNC ANCA was negative because there was narrowing and all these things. So vasculitis was definitely on the board. So those investigations that were done when they were negative. His CSF IgG was high. It was 18.7 with a range of 1.3, though MOG and NMO were negative. Definitely this IgG can be high in infection as well or inflammation as well. So then as MRI at times overreads, CT angio was planned and CTO angio was done because as the personal communication with stroke specialists from Toronto, the vessel wall imaging, they tend to kind of enhance for longer time. So we had one COVID vasculitis. So they said, instead of doing a vessel wall imaging, CT angiogram and PET would be a much more kind of give much more yield for a vasculitis to kind of denote. You get to know the progression and prognostication as well. So the CT angiogram was done where you see the distal, MCA, distal ICA, and other findings were unchanged. So definitely the angio-wise there is a progression of the disease. This is again the same. So there was a diffuse symmetrical stenosis and terminal portion of bilateral ICA and proximal portion of bilateral ACA, and MCS was there. And irregular mid-third portion basilar artery and non-visualization distal 1/3 of portion of basilar was there. So considering autoimmune versus para-infectious etiology, the infective outcome negative, the patient was started at MWH and IV methylprednisolone given for 3 days. Patient was symptomatically better though. Later, he started having headaches, vomiting, and fever. So again, we thinking, is there some atypical infection that we are harboring? Really, is it immune? What has to be done about immunotherapy? So then we gave, just methylprednisolone given was for 3 days. Then we kind of halted this methylprednisolone. But patient used to be active in interfebrile period. His appetite improved. He was active and alert. So the toxicity has gone, but the fever, vomiting, and headaches used to be there. His BP was in centiles. So later, after 7 days of Merovanco and 3 days of methylprednisolone, his CSF was, his HB was CBC was reported, where his count went to 20,000 with polymorphic predominance. His platelets were still high. CSF examination shows 20 protein, 69 of CSF sugar with 154 of BSL. His cell came down to 100 with more of a lymphocytic predominance. Here we thought of some atypical thing which is happening. So we asked for lymphocytes, malignant cells, they were negative. Again, CSF blood culture was negative, gene expert was normal, procal was normal, because definitely when we wanted to give further immunotherapy, we wanted to rule out the bacterial infection as well as atypical infection for sure. And the vancomycin was continued. We stopped doxin, azithromycin, looking at all this mycoplasma and CSF as well as ceftriaxone milk pricks coming negative. So patient continued to have fever. He had headaches, and so now the fever started becoming resistant. He never used to touch baseline and used to be toxic as well. So thought of drug-induced fever because of vancomycin. Again, vanco was stopped, Mero was continued. Ceftriaxone was added. Why? I'll just kind of come to that later. So subspecialty opinion were taken: infectious diseases, rheumatology, hemato-oncology. Everybody's like looks like infective versus para-infectious, immune process. Though we didn't get any yield in any of the infective kind of parameters. And now the toxic symptomatic patient, what has to be done? So definitely really in fix to decide the way forward, because I couldn't give even, AKT because there is no strong evidence of tuberculosis. Infection was covered up, a typical organism, at least till now a negative. And immunotherapy I couldn't give because there are like few things which are staring at me with like high counts, the fever, and definitely when we give immunotherapy, the infection may flare up. So this was a fever. You see, this is spiking continuously. 101, 103, and in between that, he was toxic, the headache. He was a little drowsy during the febrile period. So what were the option? We thought of stepping up immunotherapy, IVIG versus cyclophosphamide. IVIG is a little better best bet because the infection was one of the differentials. Further infective or immunological workup needed. Shall we go ahead with this? Bone marrow relevant investigation, depending on if any kind of infective agent which is harboring in bone marrow. Tissue diagnosis like meningeal biopsy, or we may find in the lymph node anywhere kind of a biopsy that. And start AKT with steroid, but as I said, there was no any strong evidence of tuberculosis. So to our surprise, as we know, all this report tend to come a little later. So mycoplasma pneumonia IgM is positive, which is pretty high. It was 27. It was done on day 5 of the illness. And here is the main thing: the brucella was positive. Brucella IgM was positive, and the titers were significantly higher. On probing the kid, he is kind of a mixing with dogs and cats, but not cattle. There is no kind of a sheds near his house, and no really kind of a drinking unpasteurized milk or raw milk in the family and the patient as well. So looking at the hematological causes, his ferritin was repeated. It was 54 early, which risen to 209. HLS work of fibrinogen, triglyceride was normal. His bone marrow biopsy aspiration was negative. PET done because we could find, because again, as I said, vasculitis, if at all there is extensive vasculitis anywhere else. So we definitely wanted to know. So we got a PET's whole body done, which was negative. Renal Doppler was not normal. Again, part of work of COVID antibody was done, which was positive. And we take an expert opinion. Definitely, Dr. Udani was, kind of a consultant, and I spoken to him. And looking at all these things, what we thought, okay, chalo, this could be a brucella. And then when you kind of search literature, the literature is with you. So you can get vascular involvement in 16%. You can get fever, headaches, low CSF sugars, pleocytosis, many things which can be explained with the brucellosis. And again, here, what you see is a chronic meningitis here with this kind of a IgM positive. Definitely, we would think this was one of the differentials. So, to prove that, we did a CSF and serum brucella PCR, which turned out to be negative. Immunoblot for brucella, which was much more sensitive and specific, again negative. Prolonged culture, because for brucella, you need to keep culture for weeks. So that prolonged culture for bone marrow and blood. Unfortunately, CSF, we had to kind of discard after 7 days. But bone marrow and blood culture was negative. Plus, patient started as IV ceftriaxone, which that's what I was wanted to tell earlier. So IV ceftriaxone, rifampicin, doxycycline, looking at the brucella positivity. IVIG was planned, but again, there was doubt about steroid. Few guidelines said, in chronic infection you can give, but again, there was a scope of kind of flaring it. So currently here we were thinking of, is it like only CNS neurobrucellosis? What are we thinking of? So again, we are stuck what to do because patient is becoming toxic. Only steroid or with anti-brucella treatment, empirical AKT with steroids. Step up immunotherapy, phosphamide or rituximab or any other test. So what was done in between? To started on IV dexamethasone as patient was really becoming hypertensive, irritable, vomiting, his GCS was dropping. And 4-drug AKT started on day 2 of dexamethasone. I thought I'll escalate it. I may later decide about what has to be done about it, because definitely everything was like, I didn't want to lose that tuberculosis handle and kind of make the patient worse. So the course continued. Patient was started getting drowsy progressively and encephalopathic. GCS starts dropping. He had worse headache. He would become like either encephalopathic, drowsy, or kind of irritable and kind of yelling on top of his voice. His meningeal signs were positive. His BPs were like high, even in spite of mannitol and dexamethasone. His fever continued, and the toxic look again started coming in. And with this, we repeated this MR. So MR showed, ventricular dilatation, more of a, communicating hydrocephalus with some fourth ventricle, enlarged bit, but not really comparatively less fourth ventricle enlargement. This is a again showed definitely, what was temporal half, lateral ventricles have fourth ventricles comparatively less. And the earlier, things which were there in first scan, which has become gliotic now. So those lesions has gone, and this was restricted diffusion. ADC and DWI, where you can see this kind of a restricted diffusion. But again, this was told to be artifact. There was no ADC map which was there. In MRI showed more of obstructive hydrocephalus with gliosis getting better and much of enhancement. The contrast we did later. So the basal exudate enhancement of cranial nerves, and this is coming up. And as even earlier, when those brucella came, definitely the tropical panel was done, and we sent a CSF for pyrosequencing for HDR, and 2 hours came positive. And so now here we thought, okay, now we are kind of know what is the disease. So, we'll just kind of finish this slide in a minute. So what we saw in KEM post-COVID pandemic is we had 3 multiple tuberculomas with meningitis with 5 days history only. We had 1 TBM who's like hardly 3 years with multiple CVST, all his program workup negative. And we had 2 TBM with stroke with acute history. Definitely, these all patients had gene expert positive on, 2 of them had on sputum, and all of them have gene expert. Here we couldn't get anything on gene expert, or the CSF earlier was having low sugar, those cells and proteins, and kind of a little confusing. So that's what I would tell. End my story. There was unusual tell to be or not to be. So which came to me TB or not TB. And now I waiting is mostly TBs. We have sent Brucella IgG. If at all we tend to have 4-fold higher in Brucella IgG, titers, and again we are kind of in fix, because for Brucella you need to give those anti-Brucella medication for 4 to 6 months. And I would thank I would thank you and kind of ask for the expert comments on this.
So Dr. Lokesh for the expert comments first.
And Dr. Narasimhan is also there.
Okay.
Yeah. So I think it's always challenging, the infective things, with all the advancement in the backup testing, what we have, the PCRs and various extended cultures. TB is still very, very elusive. And just information, so the neurobrucellosis, because we don't have too many of them, what is the usual cell count we see in them? And the protein, is it matching with what this child had? That would be one of the things which might give us information.
Yeah, the protein has high, low sugar, which is matching, and usually the cells are in hundreds. Here earlier we had 550 cells, and later we had
550
less
cells.
Yeah, but
Yeah,
again,
that's,
I would like to make a comment. Is the second CSF was after methylprednisolone. So again, there we were like kind of a not
I
really
know.
sure.
It's a challenging case. Yeah, I think epidemiologically common things are common. Probably in that sense, probably you start the ATT early with steroids in this sort of situation. And then as we rule out conclusively other things, probably doing that way would be safer, so that you preserve the brain as much as possible. Would be one way to go, but it's a practical way rather than evidence-based manner. Yeah, because of the epidemiology what we have in India. But otherwise, I think it's a very challenging case, Abhijit.
Yeah.
Thank you.
Thank you.
Dr. Rajesh is there, he can comment.
Dr. Narasimhan, yeah.
Dr. Narasimhan?
Dr. Rekha? Dr. Narasimhan was there, I think. Dr. Lakshmi.
He is there, he is there.
Oh, yeah, please, yeah.
Comments from Dr. Rekha?
The brucellosis I thought was more common in this Punjab and sub-Himalayan region, that side. We saw a number of cases of brucellosis when I was posted in that area, and all of them had significant splenomegaly. So I'm not sure whether you can have kind of neurobrucellosis without a significant splenomegaly.
Yeah, so basically sheep rearing kind of communities would have more of a sheep and cattle rearing communities have more this thing, and this patient needed and spleen. But then a couple of case reports were there which neurobrucellosis said, but that's what I was wanted to say. It was isolated neurobrucellosis which only can kind of come.
Can't there be a mixed infection?
I mean, yeah, of course, that's the reason we're waiting for this. I mean, kind of a convalescent sera for IgG titers for neurobrucellosis. My only thing is fix of immunotherapy and AKT because I didn't want to really start immunotherapy and then get patient worse and deteriorate more.
Post-COVID, we are seeing a lot of TBM.
Yeah, exactly.
Post-COVID, we are seeing a lot of TBM cases with unusual presentation, and mixed infections are also very common. We get scrub typhus with TBM. We get other diseases also with TBM.
Yeah. And his fever never responded to rifampicin septum. So the patient is still admitted. So couple of days back, he becomes, so last 3-4 days is becoming, fever free. And Lyme serology we haven't done because I don't know where it's being done. So definitely, good thought. We'll get it done. But scrub typhus IgM was negative. That I did.
Lyme serology can be done quite easily in all of the labs.
Okay.
We are getting it done in some of the international patients who come from Scandinavian countries and present with especially facial paralysis. So it is being done easily and can be looked into. But I would agree with Dr. Lokesh that one cannot ignore tubercular etiology in this patient. All said and done, the bottom line, it is a chronic meningitis, and we have to find out the underlying organism.
No, retrospectively, if I think now, so with this obstructive hydrocephalus and this pyrosequencing come positive, this chiasmal enhancement, this kind of a angio which is progressing, there was some kind of lesions and all these things. Now, definitely, when you think now, it's like kind of, but this is almost like 1.5 month history. The patient is admitted still involved with this thing. So, Lakshmi sir, your inputs are.
Dr. Lakshmi. Dr. Narasimhan.
I think it's Dr. Narasimhan, we are waiting for your comments. I think it's important to understand, like you have to think of, sometimes we have to always think of the uncommon manifestations of common things more.
Exactly.
And obviously, a lot of coexisting infections are there. That we have been seeing. So I think that has to be kept in mind. But thanks for presenting. It was interesting. Meanwhile, Smita, can you just ask sir whether he is in a position, because he had texted me that he was logging off because of an ICU.
Sir is there.
Yes.
Dr. Narasimhan, can we have your comment, please?
Wonderful cases. And
what about brain biopsy?
That is not done these days, I think.
Yeah,
quite unethical to do a biopsy.
No. We, in really, really difficult cases, sometimes one can go ahead and do it. Even
we have
now,
been doing it. We have been doing it, and many
Yes.
times we have found the most unusual, bizarre things, and we have found some malignancies. We have got, so we have had meningeal biopsies and all we have taken, and sometimes brain
Right.
biopsy, depending on what the situation would be. So
Yeah.
that helps.
So-
that helps.
Yeah.
Sir,
So I would
in the
agree
chat
with
box
Dr.
if you-
Shefali that if your back is against the wall and you have time constraints, the child is deteriorating, it might well be worth it. And it can be done. We've had a couple done and with very gratifying results as well.
Absolutely. Absolutely.
Sir,
Meanwhile, I
write
would
comments in the comment box if at all he is not able to kind of.
Yeah, anything, Abhijit, you can just read and answer. And meanwhile, I
so-
request Dr.
yeah,
Lokesh
exactly.
and Dr. Narasimhan, if he's there, and Dr. Rekha, Dr. Parekh, to give some take-home messages of the summary of today's presentation.
So the hydrocephalus and basal exudates happened on the third scan. Earlier 2 scans were, so CT and Angio, the first MRI didn't show anything. So this was almost 3 to 4 weeks into the illness, and definitely then the pyrosequencing came positive. So definitely it would have been low sugar, less cells are getting better. So those are something which is, I was really kind of skeptic to start AKT, but definitely, henceforth I will be definitely much more as a gene expert communicating also in the pyrosequencing, and that's definitely good utilization of pyrosequencing. When Anju madam has said TBM is now foxing us with post-COVID thing. where the things are coming so difficultly. So, I mean, this was excellent use of getting this thing. Yeah. Yes, sir.
Can you hear me?
Yes, sir.
Yes, sir. We can hear you,
Yeah,
sir.
I was struggling to reach you. The giveaway points in this case are: one is the hydrocephalus, which you picked up pretty late. Second is the chiasmal, the predilection towards chiasma. Both these things do not occur with brucella. So I would, the moment I see any predilection in the optochiasmatic area, or the moment I see either a communicating or an obstructive hydrocephalus developing on the patient, I would jump on to start the ATT and then go ahead with it. And I have never failed, because even though I was not able to prove by even the most sophisticated investigation, common things are always common, and you will find that you'll get very good results on starting the patient on an empirical ATT. This has been the case for so many of our experience all along these years.
Yes, sir.
So hats off to you that you stuck on to TB. My congratulations to you, and I still feel strongly it's the case of tuberculosis.
Yes.
Thank
Sir,
you.
I would thank you, sir. I would now request you and Dr. Lokesh first, because you or whoever first, to give some take-home messages, because the idea for today's presentation for having various acute stroke manifestations, and to have the myriad of the causes, and that is just to prime our fellow colleagues for the same. So any the take-home messages, I mean, we customarily ask the experts to give some take-home messages. So, sir, take-home messages from you.
First, the most important thing is the varied presentations which the pediatric. I was really, I'm really overwhelmed to see the beautiful array of cases being presented today. And the one good thing, I've never seen a case of maple syrup urine disease presenting as acute ischemic stroke. Then secondly, the rotational vestibular, that is a fantastic case. And Leopard attack, I was frightened to see Leopard attack producing a dissection. And madam, I think I should really congratulate you for organizing a garland of cases with beautiful presentations, a wonderful intellectual feast for all of us. Thank you.
Thank you, sir. And I wanted to tell you and all the other attendees that all of them are being recorded and are put on the YouTube, so that the YouTube links are going to be shared with the attendees. This is the 30th webinar. And sir, we've had.
I wish you all the best.
Thank you, sir. But I think it's for everybody's combined effort. All the residents who are presenting, many faculty themselves are presenting, and actually the extensive work which is being done pan-India. I mean, that is what is to be congratulated about. And what in your opinion and inputs, because I wanted that, we, when adult neurologists come as examiners, our residents sort of get scared. We need to actually, that is jokingly said, but I feel that the perspective from adult neurologists is a bit different than it is from a pediatric neurology point. And when, people from, you can focus and it has more enriched discussion. Lokesh, your take-home message, please.
Yeah, I think one of the important take-home messages, there is no standard bogline investigation to be done in all children with stroke. Like bilateral basal ganglia, unilateral basal ganglia, you are limited to only CT, brain, and CBP, ferritin, maybe a lactate, and calcium, magnesium. So you need to tailor. So posterior circulation stroke, you don't get common etiologists do a rotational angiogram after 15 days to 1 month after the stroke. Don't do it in the acute period. What it means is you need to tailor your investigations according to what you think is a possible etiology. That's very important. So apart from doing a standard CBP or a ESR, homocysteine, and those kind of things, so the other investigations should be tailored according to the presentation. And that's what I would say. Thank you.
Yeah, I may add, Lokesh, that multiple risk factors may coexist in one individual. So that should be kept in mind, especially in pediatric stroke. And secondly, as it's being said, ATV comes anywhere, anytime. And whenever in doubt, it's always wise to start the ATT, in a sick person, and then you can refute it and stop it. Once started doesn't mean you have to continue, but you're going to be, as Dr. Narasimhan said, most likely you are going to be right only. It's only going to be a rarity that you may need to stop. But I think, like we've had a rare situation where ultimately after a meningeal biopsy, we got a malignancy. That was different. But otherwise, mostly it is the same. Dr. Rekha Mittal, Dr. Parekh, Dr. Kavita, Dr. Mahesh, and
So
all the
one thing
SIG
that I
members.
would like to point out is that as pediatric neurologists, we need to have some discussion on thrombolytic therapy and its indications going forward. So all of the cases, we found many diverse causes and etiologies and things. But one area where even pediatric neurologists are a bit on thin ice is thrombolytic therapy. And I think Dr. Lokesh would be the right person to kind of throw more light on that, maybe going forward in one of the sessions.
Dr. Rekha, we'll do a
if we-
position. We can do a position paper on that, and Lokesh will be part of that, and we can decide to be that. I think because and we have Lisa speaking on acute stroke overall an update on 27th. Next week is recurrent stroke. So this thing, because we decided that we'll also have the consensus statements or some papers, so that part can be taken off as this SIG. That is very, very important.
Yeah, because we all feel a bit, we all do feel a bit jittery, especially when older children come in with stroke, the decision making and all of that. So none of the cases today would fit into that area at all. But I think that's something we need to think about.
Absolutely, absolutely. Harsh, can you make a note? He's the member secretary of the SIG. Yeah, this has to be taken care in whichever format.
Yes,
that can be discussed in the SIG, right? And Dr. Parekh.
So again, fantastic cases, and so every time I attend these sessions, it's like everything is a learning here. So the clinical approach, definitely for all the participants, everybody who presented, the clinical approach was fantastic. There's no comparison, and the way we work them up is like out of this world. I really appreciate that. And the learning points, definitely, I would agree fully with our experts today. They have made the right comments on what should be taken from here, definitely. The only thing which I say is that rare has now become contextual. So where you work makes it rare or common. This is what I've learned. So all of us have our own rare cases, and all of us also have our common cases. So in the case by Abhijit, it's just a suggestion. It's a fantastic workup, but look for histoplasmosis and Bartonella. These are two conditions, two infectious conditions which can have basal exudates. So that's how. And for Lokesh, there's something which I always wanted to comment on. Have you ever thought about why does mineralizing angiopathy have this calcification? So in the chat box I put in, we have been looking into these patients, and we've been doing CMV PCR in many of these patients, and also a control group to look at whether the CMV is higher in these patients, the CMV viral load. That's the only marker which I could think of.
Yeah, I know. We have tried that initially, Dr. Manish, but we couldn't find anything. One Chinese paper suggested small percentage of them have had that positive, but they don't have any other telltale evidence suggest sort of CMV. They have is a lenticular striate vasculopathy, which would be very unusual for CMV infection. No microcephaly, no hearing impairment, no retinal abnormalities. So we always look at calcium, lactate, because we had a child with pseudo-hypoparathyroidism with similar and bilateral infarctions. So just to not miss out on those group of disorders. But apart from that, it's not very clear what is the exact etiology. We, as a standard, do write down for all the newborn ultrasounds whether there is evidence of lenticular striate vasculopathy, and it's extremely rare, and extremely rare in most of the newborn period. Thank you.
Yeah, sure. Thank you
I'd
so
like to add
much.
one point, sir. We had studied a few cases of angiopathy, and we found that many of these patients had history of PRM, sir, PRM. Many of the mothers history of PRM or NICU admission for about a couple of days, actually. So I don't know, some low-grade infection or which can predispose them to this calcification, not very sure. But we have found almost in more than 70 to 80% of patients with malignant angiopathy, when you ask the mother either the history of NICU admission or history of premature rupture of membranes. They're not sick enough to go into ICU, but definitely we have found more than 80% found history of PRM. I think
They
this
can have, can I put in a word about this angiopathy? It's just a speculation that they can have polymorphism, IL-6 polymorphisms, abnormal reaction to infection, which is being the etiology of cerebral palsy as well. And anemia also. Anemia can be due to deficiency of adenosine deaminase, pyruvate kinase, a lot of other enzymes. They may be associated. So if we do exome sequencing, we may find out more pathophysiology about it.
Yeah, actually, we did it around 7-8 children, ma'am. Whole exome sequencing. We couldn't find an answer because we're not sure. We looked for both autosomal dominant and recessive genes with this predisposition to vascular calcification. But unfortunately, we couldn't find any answers on that. That was a small sample, but
yeah.
Any other message, Anju, from your side? No. Then Harsh.
No, thank you.
And Harsh, you are the secretary of this
No,
SIG.
no.
You have to have some message. Sangeeta, Harsh, kuch bolo, fir Sangeeta. Sangeeta,
Yes,
Dr. Kavita, Pratik, everybody in the
Yeah,
SIG.
so all the very nice discussions, especially on the mineralizing arteriopathy, the various aspects, and it was really nice cases altogether. So it's a very good learning opportunity for all of us.
Yeah, and I thank all the presenters. And Asmita, you forgot to show their certificates, which you will be mailing to them. Anybody else from the SIG wants to speak? Yeah, can you share on the screen?
Can I add something?
Show all the certificates. I think the people who presented are still there.
Yeah.
Dr. Kavita here.
Please, Kavita.
Yeah,
of course.
Yeah, so we were working on a stroke consensus guideline since last 2.5 years, and Dr. Ramesh is the chief editor. So we, of course, struggled with a very poor level of evidence available to make the recommendations. And so there was a lot of the Delphi process, and then the expert, all those rounds have happened. And we are now in the final stages of formulating the guideline. The final stage of manuscript preparation is going on. So mostly maybe in the next 2-3 months, we may be out with that guideline. So that's what I wanted to say. And excellent cases today, lots of learning. And thank you so much for making us a part of this.
Thank you. Thank you, everybody. I think Mahesh, you can then.
Yes, ma'am.
Sangeeta, you want to say something, Sangeeta? No, message for. No, okay. Okay, thanks. Close.
Very good mix of both anterior and posterior circulation stroke, all different causes. And I congratulate all the presenters and their mentors. Next week, we'll be having another interesting case with discussion on recurrent strokes. I invite all of you to attend next week's meeting also. And last Wednesday, we'll be
present cases also, beta.
Yes, ma'am. Yes, ma'am. I request all the members to please send their cases by Sunday so that we can shortlist them and we can choose some 6 to 7 cases to publish the next Wednesday. Last Wednesday, there will be a guest lecture by Dr. Paul from Canada. Please don't miss it. Thank you.
Thank you.
Good night.
Yeah, thank you. Good night.